Hello, everyone, and welcome to our webinar. My name is Tracy Cook with Sachs Healthcare Communications, and I'd like to show our audience how they can send in questions throughout the webinar. Our speaker will try to answer as many questions as possible at the end of the presentation. Please type your questions into the questions box. I'd like to introduce our moderator, Lisa Wall. Lisa has over 30 years experience in acute and chronic respiratory care and health organization management. She is currently a respiratory care manager at Highland Hospital in Rochester, New York. In her current role, Lisa works with multidisciplinary discharge transitions teams to develop COPD pathway in order to decrease hospital readmissions associated with that disease state. In 2023, Lisa was awarded a leadership fellowship in quality improvement by University of Rochester Medical Center. Lisa, welcome.
Thank you, Tracy, for the kind introduction. The title of our webinar today is From 2014 to 2022, Update on Ventilator Pneumonia and Ventilator-Associated Events. Speaking on this critical topic is a leading expert and colleague, Linda Green. Ms. Green was Director of Infection Prevention at the University of Rochester Highland Hospital until May of 2022. Currently, she is an independent consultant for acute and long-term care. She has over 30 years experience in infection prevention. She has authored and co-authored several peer-reviewed publications in nursing and infection prevention journals, textbook chapters, and implementation guides. Linda was the 2017 APIC, Association of Professionals in Infection Control and Epidemiology, President. Linda was the APIC representative to the SHE Compendium sections on ventilator-associated events and surgical site infections. She has served on several advisory panels, public reporting of HAIs, and has received several awards in infection prevention, leadership, and nursing. Linda has lectured extensively at the state, national, and international level. In 2022, she was awarded the prestigious APIC Carol DeMille, given annually to an infection preventionist who has demonstrated extraordinary leadership and visionary thinking. Our speaker has disclosed the following relationships. Continuing education for nurses and respiratory therapists. A link to obtain credit will be available at the end of the webinar. This educational activity is approved for 1 contact hour for nurses and RTs, and support for this educational activity is provided by Dale Medical Products Incorporated. Now, I will turn the presentation over to Linda.
Thank you so much, Lisa. It's really a pleasure to join the webinar today. And I have worked with Lisa for a long period of time, so I'm so thrilled that she is the moderator today. At this point, we'll get started. So the first thing is, in terms of learning objectives, we're going to identify the essential elements for prevention of ventilator-associated events, including ventilator-associated pneumonia, based on the 2022 guidelines. I'm also going to list strategies to incorporate these elements into routine practice, and I'm going to discuss the challenges and barriers to implementation of best practices. And we will go through those because, again, there are many challenges and barriers. So let's talk about the evolution of this. And really, the first VAP compendium was published in 2008. So it goes back several years. In about 2011 to 2013, we began developing the new VAE definition. And I was on that panel. And really, it was an arduous task because looking at a very different definition really required a great deal of work. There was a multidisciplinary team. Many people were involved in that. By 2014, we were able to, and I was fortunate enough to be on an interdisciplinary team with renowned experts in the field. And I think it's so important because when we came out with the compendium, it isn't just one area of expertise. We had respiratory therapy. We were represented by nursing, ANA, APIC, SHE, pulmonology, Infectious Disease Association, CDC. So it truly was an interdisciplinary process. But when we came out with the 2014 compendium, we now had the new definition of VAE. And then in 2022, there was an update to the compendium, which I'm going to talk about today. Now, clearly, the target date for the update was 2020, but with COVID, we know that that had to be delayed. So very happy to have worked on that for 2022. So let's talk about a little bit of the background and the new definition, because I think there's always a starting point when we talk about it. So part of it was taking really a 30,000-foot view and not just looking at pneumonia. And so the new definitions really include criteria for ventilator-associated conditions called VACs, infection-related ventilator-associated complications called IVACs. So in other words, you could develop another infection, which might be a complication of being on the ventilator, and then possible pneumonia. And what we do know is that the literature shows us that approximately 5 to 10% of mechanically ventilated patients develop VAEs. But when we think of ventilator-associated pneumonia and we think of other complications of mechanical ventilation, they're detrimental to patients and they do increase costs. And when you look at the attributable mortality of ventilator-associated pneumonia, it's estimated to be approximately 10%, but it can vary for different types of patients. So in terms of background, we know this, that patients on mechanical ventilation are at risk for a variety of serious complications in addition to pneumonia. And they include respiratory distress, pneumothorax, pulmonary embolism, lobar atelectasis, and pulmonary edema. And so in 2013, when the new definitions were released by the CDC, they were designed to make surveillance more objective and to expand surveillance from that alone to include additional serious complications. And I want to really hone in on the idea of objective definitions. And when we talk about some of those challenges, we want to keep that in mind. The other thing is, and there's been recent reports in the literature that we need to look more broadly at things. Other areas like catheter-associated urinary tract infections, and look at some of those non-infectious complications, because really what we're talking about is patient safety as well as infections. And I think the VAE definition was an excellent start to that. So the shift is really important because the quality improvement initiatives should ideally focus on identifying and preventing objective morbid complications. And most of those are unambiguously associated with poor outcomes. So by broadening the scope of this surveillance, we acknowledge, as I said earlier, that both infectious and non-infectious complications can arise in ventilated patients. And we really should be considering that in designing programs. So I love this particular slide because when we put patient safety first and foremost, and we look at ventilator harm, what we're really looking at is all of those types of things. Certainly, we're still going to look at pneumonia, but we're looking at morbidity. We're looking at mortality. We're looking at infectious complications. What about immobility, atelectasis, and cost and length of stay? So many of these things really all go back to ventilator harm. So let's look at VAP or VAP pneumonia in general. And one of the problems, and I was at the first meeting when we were coming up with the new definition. I will tell you that this is a real challenge because people were looking at outcomes related to VAP surveillance. The problem with the definition is that there were a lot of questions or ambiguous definitions when you were interpreting it. So this is a very nice slide by Dr. Mike Klampus in 2010, but it points out where the problems are. So they took 3 infection preventionists and they looked at the consistency in looking at ventilator-associated pneumonias, and they found a wide degree of ambiguity that definitions did not necessarily meet. So the way I interpreted it, you may not. And I remember being at that first meeting, and I have to chuckle because there was a pulmonologist that said, well, the problem with this is you have to fire the IPs because obviously some of them don't know what they're doing. But that's not the real issue. The real issue is that we know that when we look at chest x-rays, that the interpretation can be very vague. It may say possible pneumonia, could be atelectasis, could be these something else. And so we really had to come up with that new definition. And then moving on, as we did the 2022 update, we really needed to look at all of the elements and some of the things that had changed since that time. And again, as I said, I think it's extremely important that we realize that this was a true multidisciplinary effort. And having so many experts from various backgrounds really made this a very robust paper. So I'm going to look at the starting point, and I think we need to realize that there are many risks. So let's look at the risks, first of all, in VAE. Well, we know that deep and prolonged sedation is a risk, and some of the mandatory modes of ventilation are risks. High tidal volume, they've talked about, aspiration. I'll get into oral care with chlorhexidine, which is what Dr. Klampus calls one of the thorniest issues right now, excess fluid balance. So all of those things come to play when we're looking at VAE. But, you know, going back to that very big picture, and one of the things I want us all to think about when we're taking care of patients on the ventilator, and I know I've worked with Lisa and things, is what are our prevention goals? When we look at the big picture, what is it we want to do? Well, first and foremost, we want to avoid intubation. If it's necessary, we want to get that patient off the ventilator as soon as possible. Well, they are on the ventilator. We want to avoid aspiration. We want to maintain nutrition, and we want to maintain muscle strength. And these are just some of the things we can think about in terms of our prevention goals. So in 2014, when we look at the updates on essential practices, and I want to talk about the word essential practices. What does that basically mean? Well, it means that some of the data do show improvement in outcomes. It also means that the benefit outweigh the risks, and we always have to think of that. We might have practices that have risks, but the benefits definitely outweigh the risks. And so in 2014, we said avoid intubation if possible and use non-invasive positive pressure ventilation whenever feasible. And it had a fairly high quality of evidence, and that really hasn't changed. But what has changed, and I think is really significant, is there is an added recommendation for high flow nasal oxygen and non-invasive positive pressure ventilation. So I will say that the high flow really, really came into existence and is used more often now with COVID than I have seen it used in the past. So who are the patients at risk for intubation anyways? Well, we know if you have acute or chronic hyperbaric respiratory acidosis, acute cardiogenic pulmonary edema, acute hypoxemic respiratory failure, moderate to severe respiratory distress, tachypnea, accessory muscle use, abdominal paradox, and neuromuscular diseases and respiratory muscle fatigue. All of those patients are at risk for intubation, and I'm sure most of us do know that. But one of the things that was very interesting, and that was the addition of high flow nasal cannula. And it really, as I said earlier, it has gained popularity during COVID. But there are several meta-analysis reviews on the impact of these modalities. And so certainly one of the things I will say with the compendium is our references. There was just rigorous review of references, looking at meta-analysis and things like that. And high flow certainly was an important thing. The other thing that changed, and really some of these aren't so much changes as it's an improvements to what we previously talked about. So I always want us to think about the word improvement. So we look at it, we see what's going on, and then we say, wow, you know, there's more to this. So in 2014, we said we manage ventilated patients without sedatives whenever possible. And we talked about interrupting sedation once a day for patients without contraindications and assessing the readiness to extubate once a day by the SBTs and SATs. But one of the things that moved forward is we really put into that, and I should say the experts, because certainly that is not my area of expertise, but to use multimodal strategies other than benzodiazepines and use a protocol to minimize sedation and implement a ventilator liberation protocol. And I'll talk a little bit about that because you might say, well, you're pretty much saying the same thing, but let's get into that a little more. Well, in order to minimize sedation, we know that deep and sustained sedation is associated with adverse events. And when we talk about those, we know it's mortality, prolonged medical ventilation, and the risk for VAEs. And so one of the things that the potential strategies to minimize sedation include nurse-driven protocols for light sedation, daily sedative interruptions, and the spontaneous awakening trials, and managing agitation and examples, analgesics for pain and reassurance for anxiety, and many of those types of things. But if the patient is ventilated, what do we want to do? We want to minimize sedation. We want to avoid benzodiazepines in favor of other agents. But the two things that really we are looking at and are somewhat, I would say, of a change is the protocol to minimize sedation and implement a ventilator liberation protocol. So what do I mean by that, and why is that important? Well, oftentimes the SAT and the SBTs would be physician driven, and it depends on which intensivist is covering the unit. It was really kind of at the discretion of the intensivist. And one of the things that is really important is acutely hospitalized adults who've been mechanically ventilated for more than 24 hours are managed with a ventilator liberation protocol rather than no protocol. So in other words, it's not, well, let's just put this person on. Let's have a standardized protocol. And physician-led protocols can actually lead to lack of standardization. So if you leave it up to individual physicians, you're not standardized. But the important thing is, and for those of you who are respiratory therapists, once the protocol is in place, so if you have a standardized ventilation liberation protocol, It can be managed by respiratory therapy. It can also be managed by nursing. And I know when I gave a talk on this to some of my APIC colleagues, I reached out to Dr. Klompus, who was lead author and just a wealth of information. And I said, what are the two things that you think are most important? And he said the standardized ventilation protocol. Having it standardized, having the same protocol no matter who's on, to have those clearly standardized. And then the other thing that I will get into was toothbrushing. So he felt those were very, very important. And we'll talk about that as we move on. So what is the ventilator liberation protocol anyways? Well, it suggests that they be managed by a protocol. And what we've found and what the evidence shows us is that with physician-led ventilator management, there's a wide variation. And when you initiate SATs, SBTs, but with the ventilator liberation protocols, they're often led by respiratory therapy or nurses. They're sometimes computer driven, and they have been designed to standardize and enhance identification of patient readiness and liberation from mechanical ventilation. So in other words, what we've learned over the past several years is the more we're standardized, the more we're protocolized. We certainly can do individual things, but the more that those things are in place, the better the chance that we're going to achieve the goals. So when I think of all of you who are listening, I would just ask you to think about your own practices. Do you have a sedation policy? Is it standardized? Do you have a true ventilator liberation protocol or policy? How is it instituted? Who monitors it? How are you sure that you're really doing it? And most importantly, how engaged are your intensivists and your respiratory therapists? And I think that's really, really important. As an infection preventionist, which is my background, one of the things that being on the VAE task force has really opened my eyes that we are truly need to work interdisciplinary. No one of us alone can do it. And if our intensivists, our respiratory therapists, our nurses, our infection preventionists are all rowing in sync, we can truly achieve better patient outcomes. So I love this bundle. This was published by Critical Care Medicine, and it really kind of, just shines the light. And that was published in 2018. Clinical Practice Guidelines for Prevention and Management of Pain, Agitation, Sedation, Delirium. And so they call it PADIS guidelines. And it can be implemented through the Liberation Bundle. So when we think about this, we think about assessing, preventing, and managing pain, looking at both SATs and SBTs, having the right choice of analgesia, preventing delirium, assessing, preventing, and managing that delirium, which is very, very important. The early mobility and the exercise, and I thought what really was very nice in this particular one is family engagement and empowerment. And we think of a patient being on a ventilator and being sedated, but that family engagement and empowerment is also extremely important, and I think we all know this. So this is a sample protocol for liberating patients from mechanical ventilation. You have your time frame, you look at their SO2s, you look at PEEP, FiO2, and you can look at all these, but having an algorithm really does help. And then putting that algorithm as part of standard care is an important step in all of this. And although your liberation protocols may be somewhat different, having that standard protocol with the goal being getting the patient off the ventilator as soon as possible. And I think that's really important. So I'm going to move on to a really, I will say, a bit of a controversial issue, or as I heard a talk by Dr. Klompus, a thorny issue. is in 2014, we still had perform oral care with chlorhexidine. But in 2022, and looking at the evidence, looking at some of the studies, provide that daily oral care with toothbrushing without chlorhexidine. Now, one of the important things, in my background is nursing, I know many infection preventionists come from different backgrounds, but in my nursing background, I'm thinking that something as basic as oral care and nursing care can really make a difference in patient outcomes. Many of you know there's been just a ton of literature on toothbrushing, and it is associated with significantly lower VAP rates, shorter duration of mechanical ventilation, and shorter ICU length of stay. And I think that's so critically important. I've talked to colleagues, and it's very interesting. I've talked to some colleagues that have been even in an ICU for one reason or other, and they're saying that many of the ICUs are still giving you the, the little sponge things to wipe out your mouth. And so, and particularly with ventilated patients, the question is the daily toothbrushing instituted as much as possible? So, whoops, excuse me. Okay, here we go. So what happens? Well, dental plaque accumulates rapidly in the mouths of critically ill patients. And because you're in a hospital, there is a significant shift in the microbial community. So we know, our microorganisms, multi-drug resistant microorganisms, many of those, they live in the hospital. There really is a shift. And colonization with possible pathogens certainly is a leading cause of that. So toothbrushing has been found to be an important intervention. Now, people have asked, well, how do I do toothbrushing with a ventilated patient? There are several online procedures. Many of those talk about using a small toothbrush followed by suctioning or a suction toothbrush, but a very, very important strategy because our mouth is very dirty, and we're colonized with multiple microorganisms, particularly when we're in an ICU. So what about oral care? Well, first of all, we wrote this article in 2014, and it was the reappraisal of routine oral care with chlorhexidine gluconate for patients receiving mechanical ventilation. So this is a little older article, almost 10 years old, but there certainly was some emphasis even at that time looking at that. And one of the things that is extremely important is if you're looking at the use of chlorhexidine and you're saying, well, the literature shows it is a decrease in VAP, but you don't have a really consistent or good VAP definition, you're really talking about apples and oranges sometimes because the definition was so not consistent, so to speak. So we did find at that time that there were, that in cardiac surgery, that seems to be the one area where chlorhexidine is used and has shown better outcomes. And the reason for that may be shorter ventilation in many of these patients. I'm not saying all cardiac patients, but when we look at some of our cardiac patients, we know that they are extubated in short periods of time. So I'm not sure really about that. But in the discussion and what we were looking at is CHG was definitely associated with a high risk of mortality in non-cardiac surgery patients. And there are several meta-analyses to look at that. The effectiveness of CHG of different strengths, preparations, or frequency was inconclusive. And there was no evidence for an association between CHG and reductions in duration of ventilation, duration of ICU stay, or antibiotic exposures or oral health issues. Now, one would say, well, why does chlorhexidine, why do you say not to use it? Maybe it doesn't work, but why would we not use it? Well, there certainly, when you look at other outcomes, when you look at mortality, when you look at other types of potentials, it did seem that there was a slight increase in mortality to those that use CHG. And oral mucosal lesions are common adverse events with chlorhexidine. So first of all, we know chlorhexidine works well on intact skin, but we've got our mucosal there. They found mucosal lesions. The other thing that they found oftentimes, which may have led to some adverse outcomes and mortality, was microaspiration of the CHG. Now, one of the questions that often comes up is there's still a number of studies that show a positive effect of CHG, and there are some studies that do show that. Most of the studies that the team looked at, particularly related to this, were open label studies. In other words, people were using CHG, they were looking at outcomes, but when they randomized it, they found poorer outcomes in the CHG group. Still an issue that many people certainly are dealing with. It's still used quite a bit, but that is the evidence behind it. And when you look at not only VAE, but you begin to look at mortality and some of those other outcomes, CHG really was associated with it. This is a nice single study, retrospective study. They had 82,274 patients. Low-level exposure to chlorhexidine oral care was associated with increased risk of death. And the association was stronger among patients, even in those with a lower risk of death. So that was it. So the data kind of argue against the indiscriminate widespread use of chlorhexidine oral care in hospitalized patients without a proven benefit. So I'm going to move on right now to the discussion on nutrition. And this is interesting as well. So in 2014, we looked at initiation of parenteral nutrition in critically ill patients within 48 hours of ICU admission with an increased risk of nosocomial or healthcare associated infections and mortality with initiating parenteral nutrition. So especially on or after day 8. So we do know that. We know that parenteral nutrition is associated with bloodstream infections, central line infections. And so we certainly addressed that, or the compendium addressed it in 2014. But in 2022, the recommendation was to provide early enteral nutrition rather than parenteral nutrition. So in other words, we're going to do the enteral nutrition, the tube feedings. That's where we would like to go, except in maybe some unique circumstances. But, and we really looked at some of the meta-analysis where they said, well, maybe all patients should get post-pyloric feedings. Did not really seem reasonable. Enteral nutrition certainly was, the standard of care. But what we did put in there, and I know I researched that area in particular, is that you should consider post-pyloric feedings in certain patients that are very high risk for aspiration. So, patients with swallowing, patients with stroke or neurological conditions, you may want to consider the post-pyloric feedings rather than a parenteral nutrition. But when you look at the risk and benefits, we're still recommending early enteral nutrition unless you fall into one of those high-risk groups. Now, early trach. early tracheostomy, and this was interesting, but in 2014, early tracheostomy was generally not recommended. They said that it really had no impact on ventilator-associated pneumonia rates or the average duration of mechanical ventilation. But in 2022, it was added as a special consideration. So this is an area where in certain groups, it may very well be a benefit to go to early tracheostomy. And, you know, some of the data shows a meta-analysis of like 17 randomized trials suggests that early tracheostomy within 7 days of intubation may be associated with a 40% decrease in VAP rates, less time on mechanical ventilation, and fewer ICU days. It did not, though, reflect mortality. But what was put in the compendium basically was that decision makers should integrate these potential benefits with each patient's values and preferences. So in other words, we really have to look at that. It would be an individual decision, but something that you may want to look at. Now, preventing aspiration, as I said earlier, recommend enteral versus post-pyloric feeding in most circumstances. And again, patients who are at high risk for aspiration, stroke, and there are a number of patients who have severe gastric reflux. So we want to look at those again, and then certain neurological conditions as well. Now, the physical conditioning, that's another thing. You know, we know that, but early exercise and mobilization programs may shorten duration of mechanical ventilation, reduce ICU length of stay, lower your VAP rates, increase the rate of return to independent function. And, you know, we really want to think about those things in these ventilated patients because we certainly want them to return, if indeed they were in the beginning, to independent function. So there isn't any consistent association between that, but it's certainly, there are some financial modeling that suggests that early mobility programs might be cost saving. Now, I love this particular diagram comes to us, this progressive mobility diagram from AHRQ, Agency for Healthcare Research and Quality. And I know many organizations have different levels, but again, they look at that, they have different levels that they look at in terms of PEEP and all of those types of things. And so you can see where you look at your RAS scales, you see what level they're at, and it's really called a progressive mobility continuum. And I think it is very, very helpful. So another recommendation in 2014 was to utilize endotracheal tubes with subglottic secretion, moderate drainage ports for patients expected to require greater than 48 or 72 hours of mechanical ventilation. And what they did in 2022 was really reclassify this as an additional approach. And I think there are many reasons. And one of the things is that depending on, you know, how long the patient's going to be ventilated, if you have to put in a new tube, many of those types of things. So that's just considered an adequate device approach. And not recommended was oral care with chlorhexidine. So we know that probiotics, polyurethane endotracheal tube cuffs, tapered endotracheal tube cuffs, automated control of endotracheal tube, and frequent endotracheal cuff pressure monitoring. None of those are recommended. So, you know, many of the changes that we have seen really focus on new evidence They focus on standardization and development of protocols. And the other thing I think is really important is that we look at this idea of recognition of synergistic effects. So if you do one thing, it may impact other things as well. So we have a lot of barriers to rigorous adherence. Uptake by hospitals typically has been what we would call heterogeneous. We need more studies on preventability, and we need some of the major barriers to greater adoption of surveillance and prevention include ongoing misunderstanding or the lack of sympathy for the purposeful differences between VAE and VAP. Now, I'm going to say that again because ventilator-associated events encompass all of those. And again, looking beyond just the pneumonia. And the other thing that has been a barrier is that there are not regulatory mandates. So we do know that many hospitals are monitoring that. Many states have initiatives, a lot of compelling hospitals to prevent VAE, but it is not a mandate like many other things are. So again, I talked about CHD, peptic ulcer prophylaxis, which was in the very early guidelines, and lack of standardized protocols for weaning. So those are some of the challenges. Well, I like to use this because I think it's incredibly important. It's one of the strategies. It's called the 4E's model. And they highlight this. There are many models, but I love the 4E's model because I think it really speaks to what we need to do. We need to engage the team, develop your local champions, use these peer networks. We need to educate and have the materials so we know what to do. We need to execute, improve our processes, standardize, build our bundles, and then monitor outcomes and review our cases. And I think if you're tracking VAE, it's really, really important to review your cases and say, is something wrong here? What's going on? And what can we learn? And oftentimes I look at these more as what you would call a mini root cause analysis. So other strategies, including nursing tools, developing interdisciplinary rounding tubes with respiratory therapy, changing any changes in the past 24 hours, how the patient's responding, looking at all of those patient-specific factors, those are important as well. And then in terms of standardizing mobility, this was a really nice organization of things from Johns Hopkins, and they used an 8-step approach, which looks at prioritizing it, making goals, mitigating any barriers, having local interdisciplinary roles. You know, oftentimes there are barriers because there's not the resources in ICUs. Education and training, workflow integration, giving feedback, all of those again. Now I'm going to speak for just a couple of minutes on some of the special populations before we end in about 5 minutes or so, but avoid intubation if possible because continuous CPAP ventilation, many of those things high flow, those are things, success rates though, in preterm neonates are greatest for those delivered above 28 weeks gestation. But they have found that many premature neonates can successfully be supported with non-invasive positive pressure ventilation. And managing them without sedation, caffeine therapy within 72 hours after birth to facilitate expedition, assess the readiness to extubate, take your steps for unplanned extubations, CPAP and post-extubation period. And again, we're back to the regular oral care. And in pediatric patients, avoid intubation and reintubation, avoid fluid overload, regular oral care, elevate that head of the bed, and use your cuffed endotracheal tubes. So some of the key points, and I'm just going to talk for a moment about non-ventilator healthcare associated pneumonia before we end and open it up to questions in about 5 minutes here. But one of the things that the compendium addressed, and I want to highlight this is really not the crux of our webinar today, but I think it's something that we all should be thinking of. Non-ventilator hospital-associated pneumonia is one of the common and morbid healthcare-associated infections. But unfortunately, it's not tracked, it's not reported, and many hospitals don't actively have initiatives to prevent it. And so there has been a national call to action. They've launched a national healthcare conversation about non-ventilator associated pneumonia, adding prevention measures, and some of those are many things that we talked about, the toothbrushing, the preventing aspiration. They really have wanted to challenge healthcare systems and insurers to implement and support it. And they really want to encourage researchers to develop new strategies. So when we talk about post-surgery aspiration, many things like that, and oftentimes you'll find some hospitals have done an amazing job, but others really haven't attacked this non-VHAP. And so it's important, it was addressed here. I think we're going to see more and more coming out on it, and hopefully we'll be able to see what that's going to entail. So, just a couple things: elevating the head of the bed or have patients in a chair for meals. Some of the basic nursing things, and I think that's one thing I love about the VAE compendium, is it's talking about some of those basic strategies that many of us have known for years. So, again, when we talk about mouth care, poor oral care, increased bacterial counts, reduce salivary flow. And the interesting thing, within 24 to 48 hours, these pathogens become colonized. The patient begins to have those as part of their flora. And if they aspirate at that time, it certainly can cause pneumonia. So I'm just going to talk for a minute or so before we end about the infection prevention team. What you can do if you're an infection preventionist: monitor, internally report patient outcomes, assist with monitoring of adherence rates, communicate your outcomes to key organizational stakeholders. Be sure you give feedback to frontline providers. Make sure you give feedback to respiratory therapy, are so incredibly important. And reporting this data back to providers and leaders can really, really help. So compliance and increasing number of centers now have quality collaboratives showing how multiple measures can reduce VAE and VAE rates. And in conclusion, what we really want to do, and I know I've gone through that quickly, but that's just a high-level overview. But what we really want to do is reduce VAE, because it is an important aspect of patient safety. And if we have that coordinated interdisciplinary approach, which is so necessary for success. So again, no one of us does it alone, we do it together. And I am happy to turn this back to our moderator, Lisa. Thank you so much. And I'll let Lisa moderate the questions.
Thank you, Linda, for such an informative session. Before we get to questions, I'd like to inform our viewers how to obtain their continuing education credit for this session. As a reminder, this educational activity is approved for 1 contact hour. To obtain your continuing education credits, you log into www.saxtesting.com/P. You will need to register at the site. Complete the evaluation, and upon successful completion, you will be able to print your certificate of completion. And again, many thanks to Dale Medical Products Incorporated for supporting this educational activity. Now we will get to our questions. No, I'm sorry. An archive on-demand version of this webinar will be available on www.perspectivesinnursing.org. An email will be sent to all registrants when it is available, and the on-demand version is accredited for CEs. We will now begin our questions. Do you have a few, Linda? Is there a found benefit to bolus feeds rather than continuous feeds in relation to aspiration risk?
I have seen that many people do use bolus feeds. I think it really depends. I wouldn't say that necessarily I would classify it as best practices, but it does make some logical sense. However, sometimes the bolus feeds certainly can cause regurgitation. So that's it's one of those that you have to look at the benefit and the risk, and sometimes the two are not. So it really does depend. I wouldn't say I would say that it's a sound improvement.
Second question. How often is considered too frequent for cuff pressure monitoring?
You know, I really can't answer that. Certainly you don't want to. I think the recommendations are not to do it. I would not give you an example of an hour. Lisa, I don't know if you have encountered that in your respiratory therapy or not, and what the standard is that you're used to.
Well, someone else mentioned in the questions that they are at their facility, they check the cuff pressures Q-shift. And that is what we are doing also, because we have to balance it against injuries that can occur due to high cuff pressure. So we are still doing Q-shift with 2 shifts twice a day.
I think to that question, I think it's a good question, and I would say I probably would not do it any more frequently than that, and in some cases they probably do it less frequently.
Excellent. Third question, could you please comment on if we could implement one single change to get the best outcome for reducing VAP? What would that change be?
Do you mean overall VAE or VAP, or overall VAE? I'm thinking.
Question says for reducing VAP.
Okay, for reducing VAP in general, if I were to do one thing consistently, I'm looking at really continuing, because if you get the patient off the ventilator sooner, you reduce VAP. So I would say the one thing is making sure that your protocols are consistent. You know, we talked about the liberation protocol, making sure that they're standardized, that we're using them on patients consistently. But I'll use the 2 interventions because I also think that the toothbrushing, at least every shift, is important. So I think those 2 recommendations are probably the 2 things that can make the biggest difference, so to speak.
Okay. Another question, what is a realistic benchmark for VAE?
Well, the realistic benchmark, it's really hard to put a realistic benchmark for VAE because it looks at standardized infection ratios. And right now, I know there is some publications out there. CDC does an annual report on VAE rates. And I think you start, obviously, your realistic benchmark should be a standardized infection ratio. It should be less than 1. And so what I always look at with benchmarks is I pull the most recent CDC publicized data. I look at where the organization is, and then I decide where I want to be in terms of a benchmark. And using your benchmarks, looking at the CDC data, where it is, and move from there. So I can't say it's a specific benchmark, but clearly I would want my standardized infection ratio to be below 1, and then I would look at the CDC data to see where the average is, and my goal would be to continually reduce that.
Excellent. Another question, when toothbrushing was used, did it make a difference? And were they using regular toothpaste?
Some institutions did use a toothpaste, but the most important thing was the friction of the rubbing. And as I said earlier, in some of the meta-analysis that were blinded, you found that they found that toothbrushing really did make a difference. There's no doubt about it. And I think that's some of our most compelling data right now. And it's something that has been ignored in many, many cases in intensive care units.
Okay. Here's another question. How should non-avoidable VAEs be handled? My trauma ICU has done many RCAs for IVACs, but these conditions are based on patients that have severe pulmonary contusions that we expect to blossom over 48 hours or so.
How should it be handled? I think there are many patients that are going to be at risk for VAE. There's no doubt about it. But I always think within some of those risks, there is an opportunity to look at those and to ask yourself, first of all, did we follow all the protocols? That's number one. Did we really follow all of our protocols? Were there protocols missing? And so I like to not only look at outcomes, I like to look at processes. What's the connection between the processes of care? Am I doing everything I can in terms of processes? And if my patient still gets a VAE, then maybe it was unpreventable. But what I found over my years in infection prevention is we always like to say, well, these are non-preventable. And if I'm following my bundles 100%, if I'm following everything, if everything that could possibly be implemented is done, then I could say they're non-preventable. But what some experts have shown is even in those cases where you might say they're not preventable, there are opportunities for improvement. So I always look for the opportunity to do a better job, and not every time will it be prevented, but oftentimes you will find some gems there that you could do something better.
Excellent. Thank you, Linda. I think that we are out of time as far as the questions. That we had some great ones. I do want to thank everyone for attending this webinar, and I will turn the presentation over to Tracy for some concluding remarks.
Thanks, Lisa, and thank you, Linda, for such a great presentation. We would like to talk about our survey. Immediately upon the conclusion of this webinar, you will be presented with an online survey. Please keep your web browser open, and we appreciate your feedback. As well as for the CE Certificate of Completion, in 1 hour following the conclusion of this webinar, you'll receive an email with instructions and this link to obtain your CE credits. You can go to www.saxtesting.com/P and then add another /. It should work. If you're having issues, you can also try using the Chrome browser to access your CE credits. Again, we'd like to thank everyone for attending, and we hope you have a great rest of your day.